Welcome back to my channel. In this video, we will learn about acute lymphoid leukemia ALL or acute lymphoblastic leukemia, a type of blood cancer. We will explore what it is, how it develops and how it's diagnosed. ALL is a type of cancer of the blood and bone marrow. How the term ALL came? The word acute in acute lymphocytic leukemia comes from the fact that the disease progresses rapidly and creates immature blood cells rather than mature ones. The word lymphocytic in acute lymphocytic leukemia refers to the white blood cells called lymphocytes. It's also known as acute lymphoblastic leukemia. Let's refresh about lymphocytes. They are WBCs that help the body to fight against infections and diseases. That means they play an essential role in our immune system. Previous classes we already discussed, so I hope it's not necessary to discuss again. Temporarily, lymphocytosis usually means that your body is working perfectly. Means it is protecting you from germs that make you sick. But to be careful, it will be a sign of more serious conditions like leukemia, lymphoma. Okay, let us come to the topic. Acute lymphocytic leukemia is the most common type of cancer in children and treatments results in good chance for a cure. Acute lymphocytic leukemia can also occur in adults, though the chance of a cure is greatly reduced. In children, the highest incidence occurs between the age of 3 and 7, with 75% of cases occurring before the age of 6. Adults, a secondary increase in incidence after the age of 40. 85% of cases are B-cell ALL affecting both sexes equally. 15% of cases are T-cell ALL affecting males more often. The genomic classification in ALL is characterized by primary chromosomal abnormalities and secondary deletions and mutation, which involves in leukemiogenesis. What is leukemiogenesis? Transformation of normal cells to leukemia cells. Okay, let us see how the lymphocytes are classified. Lymphocytes are classified as T-cell, B-cell and natural killers, NK cells. Okay, please come back to the topic ALL. There are two main types of acute lymphoblastic leukemia or acute lymphocytic leukemia: B-cell acute lymphoblastic leukemia and T-cell acute lymphoblastic leukemia. B-cell is the common type. B-cell acute lymphoblastic leukemia affecting B-cell that make antibodies and fight infection. It's almost 85% of children and 75% to 80% of all adult cases. Then T-cell acute lymphoblastic leukemia, this type affects T cells which kill germs and support other immune cells. It makes up around 25% of adult cases and 12 to 15% of childhood cases. A third type, it's very rare, natural killer ALL. Now let us discuss about classification. Classification is FAB classification and WHO classification. FAB is the oldest method of classification. Now most of the doctors are following WHO classification for the treatments. According to FAB classification, L1, L2 and L3, three lineages. In L1, small blast size will be small and uniform. Scanty cytoplasm, round nucleus, small nucleolus. Okay, round nucleus, small nucleolus, scanty cytoplasm and small sized blast. In L2 lineage, it's very easy to identify in the blood film because the blast size is large with irregular size. More cytoplasm. See, when we are comparing NC ratios, the cytoplasm is more. Prominent nucleus. L3, large blast with uniform size, abundant cytoplasm, round nucleus, prominent nucleolus. Okay, come to the WHO classification. WHO classification is regularly updated. When we are checking medical journals, we can see this with new informations and subtypes based on ongoing research. The WHO classifies acute lymphoblastic leukemia into two main categories: B lymphoblastic leukemia and T lymphoblastic leukemia. Within these, further classification is based on cytogenetic and molecular genetic criteria as well as immunophenotyping. This includes B lymphocytic leukemia includes subtypes with specific chromosomal abnormalities such as hyperdiploidy. Hyperdiploidy means higher than normal number of chromosomes. Hypodiploidy, lower than normal number of chromosomes. BCR-AB1 like cases with gene expression profile similar to Philadelphia chromosome. What is Philadelphia chromosome? Any idea about Philadelphia chromosome? The Philadelphia chromosome or Philadelphia translocation is an abnormal version of chromosome 22 where a part of Abelson-Murine leukemia ABL1 gene on chromosome 9 breaks off and attaches to the breakpoint cluster region BCR gene in chromosome 22. This balanced reciprocal translocation between the long arms of 9 and 22 chromosomes result in the fusion gene BCR-ABL1. The oncogenic protein with persistently enhanced tyrosine kinase activity transcribed by the BCR-ABL1 fusion gene can lead to rapid and uncontrolled growth of immature white blood cells. So come to the point. Okay, BCR-ABL1 like cases with gene expression profile similar to Philadelphia chromosome ALL but lacking the BCR-ABL1 translocation. This can further divided into ABL1 class rearranged or JAK-STAT activated and not otherwise specified subtypes. Then other specific cytogenetic translocation like translocation of 9 to 22, Q34 to Q11, BCR-ABL1 fusion, translocation of 4 to 11, Q21 to Q23, MLL-AF4 fusion. What are the risk factors? Let us go to risk factors. There are certain risk factors for developing acute lymphoblastic leukemia. There are age factors, genetic factors, race, radiation exposure, sex and viruses. Important at the age under 15 and adult over 50 years. Genetic disorders, conditions like Down syndrome and Fanconi anemia can raise your risk. Research is saying that white people have a slight higher risk. Radiation exposure like during fetal development or from past radiation therapy. Then girls under age 1 are higher risk than boys. After age 1 the risk is higher for males. Some kind of viruses like Epstein-Barr viruses and human T-cell leukemia may raise the risk of ALL. Let us discuss about clinical features. Imagine your body's defense team going wrong. That's what happens in ALL. There will be bone marrow failure and organ infiltration. Due to bone marrow failure, anemia, neutropenia, thrombocytopenia. Organ infiltration, this causes tender bones, lymphadenopathy, splenomegaly, hepatomegaly, then meningeal syndrome. Fundal examination may reveal papilloedema and sometimes hemorrhages. If lymph node or solid extranodal masses predominant with less than 20% blasts in the marrow, the disease is called as lymphoblastic lymphoma. But the treatment is same like ALL. Radiography may reveal lytic bone lesions and mediastinal mass caused by enlargement of the thymus and or mediastinal lymph nodes, characteristics of T-cell acute lymphoblastic leukemia. If you are coming to bone marrow failure, anemia, due to anemia, the patient will be pale, lethargy and dyspnea, neutropenia. Due to neutropenia, our defense system is going upside down. So the patient is having fever, malaise, throat and skin respiratory infections. Due to thrombocytopenia, spontaneous bruises, purpura, bleeding gums, menorrhagia, like these symptoms. Let us come to the important part of our discussion. Diagnostic approach. What are the diagnoses related with the ALL? As usual, at first we have to go for blood test. Blood test may reveal too many or too few white blood cells, not enough red blood cells and not enough platelets. That means if we are checking for blood film observation, we can see thrombocytopenia, leukocytosis or sometimes leukopenia, RBCs will be less, anemia will be there. So after blood test, if the doctor is assuming it as leukemia, then they will go for next step, that is bone marrow aspiration. A healthcare professional uses a thin needle to remove a small amount of liquid bone marrow, see mostly from the pelvic area. Same time a bone marrow biopsy also done. Second procedure, from here you can see a small piece of bone tissue and the enclosed marrow is removing. Lumbar puncture, cerebrospinal fluid is collecting. Need to check whether cancer cells have spread to the spinal fluid. The spinal fluid is collecting from the thecal area. Then imaging test. See, we can see here some morphological changes during ALL. The first picture you see here, lymphoblast shows scanty cytoplasm without granules. If you are coming to here, lymphoblasts are large and heterogeneous with abundant cytoplasm. You can compare these two pictures. You can see here scanty cytoplasm without granules, here abundant cytoplasm. And coming to third picture, lymphoblasts are deeply basophilic with cytoplasmic vacuolation. You can see the vacuoles in the cytoplasm like monocytes. This is bone marrow. Acute lymphoblastic leukemia, bone marrow cells staining positive for TDT by immunoperoxidase. We can discuss one case study here. There is a male patient with 37 years with general weakness and soreness in lower limbs. See the blood picture. There is a flag for blast, NRB. Here it's not mentioned in the slide. There was a flag for blast, NRBCs, left to shift, lymphocytosis and thrombocytopenia. Yes, if there is any flag in the blood count examination, you should go for further validation with blood film. When we are going through slide review, it was observed that WBC and differential were almost normal. Also here RBC parameters also showing normal ranges. However, CBC report shows thrombocytopenia. In the blood film also there is thrombocytopenia. So the conclusion is it's the case of ALL as there is blast cells 16.5% of lymphoblast. See here some difference between ALL and AML. See the rate of progression, both are acute. Main affected cell lineage for ALL, T cell and B cell. For EAML, myeloid series. Typical age at diagnosis, ALL is mostly affecting children. AML adults can occur at any age. Common symptoms almost same. Then key diagnostic features. In ALL, high number of lymphoblasts in bone marrow and blood. In case of AML, high number of myeloblasts in bone marrow and blood. So further studies like immunophenotyping, identify specific lymphoid lineage in the case of ALL, and in case of AML, cytochemical stains to identify specific myeloid lineage, and there will be ore rods in the cells. Now that we understand the basis of ALL, to sum up, ALL is a fast growing cancer of the blood and bone marrow that mainly affects children but can occur at any age. Early detection, diagnosis and proper treatment can make a big difference in outcome. We have covered the key points about ALL. In the next class, we will explore CLL and CML, a slow growing blood cancer. See you there. If you found this video helpful, don't forget to like, share and subscribe. For more educational content, stay informed. Thank you.